So we're next going to hear from Dimitri Pournaras, who is from the North Bristol NHS Trust, and is going to talk to us about treating obesity as a disease, a clinician's perspective. Thanks, Dimitri.
Well, thank you. Thank you for having me. Good morning. This is North Bristol NHS Trust, where I work, and I'll be talking to you about 5 concepts and 1 landscape in the next 10 minutes. These are my conflicts of interest. I work with a variety of organizations in the field of obesity. It is a complex disease. We need multiple interventions, but perhaps my most important conflict of interest is that I am a full-time NHS surgeon. I spend most of my days, and sadly quite a few of my nights, operating not only people living with obesity, but also I do emergency surgery, I do major trauma surgery, I do some cancer surgery, and I see obesity outside the obesity clinic. I also did a PhD on an obscure molecule 18 years ago called GLP-1, and now I read about it in the national news. So I'm going to talk to you about treating obesity as a disease, but moving beyond talking about it and actually doing it. There is a difference, because I think we are talking about treating obesity as a disease, but the reality is that we are not doing that. So language matters. Stigma is not peripheral. It's not only important because it has impact beyond obesity. It's important because it affects the disease. People who stigmatize their condition, the disease of obesity, they get worse outcomes, and we have data for that. Obesity does not cause stigma. Stigma causes obesity, and that's one of my take-home messages. We have to be precise. It's not just about being kind. It's also, and we have to be compassionate. And the one treatment method that works via the intra-auricular route, via our ears, it's not a GLP-1 receptor agonist. It's words of compassion. That's one aspect of it. The other aspect of it is precision. So if I ask all of you today, if you would consider me as hypertensive, if my blood pressure was 210 and my diastolic was 130, most of you would say yes. But if that happened last year, and I'm now on 3 tablets and my systolic is 120, you would not consider me hypertensive. In fact, I'm normotensive. But I have the disease of hypertension. I may not appear depressed right now, but I may have the disease of depression. I may have a BMI of 25, but if my BMI was 40 and I was on Wegovy or tirzepatide or had a gastric bypass and my body mass index is 25, I have the disease of obesity, but I do not have the condition. And we need to change our terminology as researchers. This is work we did some years ago. There's no such thing as morbid obesity. There's no morbid cancer. It's a disease. It's severe and complex obesity. People don't fail treatments. Treatments don't work for people. And we need to change that. And I can tell you that this does have an impact from an editorial point of view, and it matters to patients. We've asked people, and there's nobody better in this room than Karen Clare, who's done a huge amount of work here. We've asked people if it matters to them. It really does. And the next aspect I'm going to talk about is that volition is not relevant to biology. I see a lot of people who are very motivated to lose their cancer or to get better treatment of the hypertension. I'm very keen for my insulin to work. It doesn't make it any better. The only volition we need is for people to seek medical therapy and to comply. That's the only volitional aspect of what we do. It's all biology. This is the largest series of gastric bypasses in this country. There are 2,000 people there. Everyone is a black line. These are people I operated when I was a very young registrar with no gray hair. And look at me now. This is 20-year data. And you see that some people do really well and some people do not so well. And I can tell you, we cannot predict those. It's not the motivated people who do well. It's not the intelligent people who do well. It's not the people who have a specific color of the eyes. It's biology. And we know this for all other treatments. And we know that every biological phenomenon is a bell-shaped curve. We tend to forget that when we talk about obesity. So this is just a model. This is a diet. This is a medication, Liraglutide diet that is the previous generation of medications now. And you can see the bell-shaped curve. And the same thing happens with endoscopy treatments and surgery. All we see is a shift towards the right when the treatments get better, but we cannot predict who does better or worse, and that's a biological phenomenon. Telling people to try harder is not going to make the chemotherapy work, and guess what? It doesn't make the GLP-1 receptor agonist work better. It doesn't make my Roux-en-Y gastric bypass work any better. Multimodal treatment for obesity is a concept that was introduced to this month 10 years ago. It's a Lancet editorial that I happened to be co-author at the time in September 2015, where we talk about combining modalities. And the way to do that is we need to escalate treatments where they don't work. What we do in obesity is we give a lifestyle modification or a drug, and when it doesn't work, we tell people to go back and try harder to make it work. That is not going to be a successful strategy. So we need to be escalating treatment. We need to stop the treatments that don't work, just like we're doing chemotherapy. When the chemotherapy doesn't work, we stop it because we're getting side effects and risk. And we need to change the treatments that are only working partially, add treatments when things are not going well. But the key question we have, and we have no answer to that, what is the target? So obesity is the only disease that we have no target. The target we have, the target that the regulators are using, is 15% weight loss, 10% weight loss. Please name one condition that we treat based on the starting point. We don't ask HbA1c for people with diabetes to work 15% improvement. We do not ask people with high blood pressure with a systolic of 200 to just improve it by 20%. We have a specific target, and those targets are becoming personalized, and they're becoming very, very accurate. And we need to do research on that. We need to start asking the question. And the research that Nick Timpson and his group, and a lot of people here, I see the two Emmas at the back as well, are going to tell us how we're going to treat those targets. If we're going to find people with polyps, colorectal polyps that are high risk for cancer, that could be a target. But we need to know that. We are miles away from that. We need to be asking that question, and we need to be working on it. I keep hearing questions about workforce. The most often people say, what are we going to do with all these expensive bariatric surgeons, such as yourself? Well, when we find H. pylori, many years ago, many decades ago, nobody worried about that. If tomorrow in the Lancet we find a new therapy for cancer, is anyone in this room really worried what we're going to do with all these oncologists? We're going to find a way to use them. We will retrain. The system collaborate and sort of calibrates, and we find ways of using the workforce to treat our population. So if we need to have more people prescribing a medication, then people like me need to stop doing keyhole surgery and prescribe medication. It will happen quickly. And if we need more surgeons to do the operations I do, we can train the people. So workforce considerations are minor details. It's not what should be driving healthcare. It's not just driving progress. And finally, the abuse of treatments does not determine their use. So the dominant narrative at the moment in the news is about people who take GLP-1 receptor agonists, that they should not be taking them, perhaps abusing them, or getting side effects. Well, I can tell you that every year there's a number of young people who have to have a liver transplant. That is one of the biggest operations you can have as a human being. And that is because of paracetamol. So paracetamol that you can get in our supermarkets can give you liver failure, and you need a liver transplant for that. That has not stopped any of us giving paracetamol when we need it. Any painkiller that you can discover tomorrow will be available in the streets within 5 minutes. But that does not stop us from giving people analgesia when we need it. There will be people who will abuse the medications. There will be people who will abuse treatments. We just need to regulate that. That should not be the driving narrative. And I'll make a final comment about inclusivity, if you like, of all treatments. We do know, and it was mentioned earlier on about clinical trials, we do know that the people involved in clinical trials in obesity are very different to the population who needs the treatments. And we have data from a systematic review of all the FDA clinical trials, all the trials that approve the medications. And we know that the vast majority of people are Caucasian, females with a BMI of 35. And that is not what Ken said earlier on. These are not the people we need to be treating. That's, in fact, if you have to have a high BMI, if you have to have obesity and you can choose everything else, I would choose to have to be Caucasian and to be female, and I would choose my BMI to be 34. But the disease burden is elsewhere. I will finish with my landscape. So I had to show something from Bristol, and that is the last flight of the Concorde. And what I want to show here is the fact that the speed of change is spectacular. So the crossroad moment, in my view, was 4 years ago when we realized that GLP-1 receptor agonists can now give us a weight loss treatment of a weight loss effect of about 15%. That has been a massive change. And see what happened in the last 4 years. Today, if you read the news today, a very promising clinical trial has demonstrated that oral GLP-1 receptor agonists have a good clinical outcome. So things are moving so fast, and therefore our research needs to be really adaptive to that. We can't be looking at this with the view that this is a slow pace kind of build. Thank you very much for listening.